Good afternoon, everyone. Welcome to the Ziemer Lunchtime Symposium for this webinar for ESCRS. So this is a very unusual year, and this is the first time we'll be doing this lunchtime symposium with a webinar. I think that probably your lunch this year will be better than it has been in the years gone by, because you'll be eating at home probably with a glass of wine as well. So we have a whole panel of speakers from all over the world. So we have speakers from Asia, speakers from Europe, and speakers from South America. So you'll be truly well represented from what you'll be basically hearing. The program is split up into three parts. We'll be having a little bit of an update on the keratoplasty module, a few talks on the cataract module, and then at the end we'll be talking about exciting new developments with the lenticle extraction module. So our first speaker, Professor Schibinger from Vienna, Austria, is going to be talking about interesting use of the femtosecond laser to be used for dark surgery. Gerald, start your talk.
Thank you, Charles, for having me here. And thank you for giving me the opportunity to give a presentation on the results of femtosecond laser-assisted dark surgery. We know that with the femtosecond laser, there is the opportunity with dark surgery to increase the outcome of keratoplasty in especially keratoconus patients. We know that dark surgery leads to potential advantages concerning reduced risks of intraocular, intraoperative risk like intraoperative bleeding or postoperative endophthalmitis. There is a lower risk of graft endothelial rejection and a potentially longer graft survival. Several randomized controlled trials have been shown that visual acuity might be the same or a little bit lower in dark cases. However, endothelial cell density and the failure or rejection rates are lower in the dark group. So when we look at the typical cases or patients that are receiving dark surgery, which are younger patients with keratoconus, and we look at the average survival of penetrating keratoplasty of about 50% after 20 years, the potentially reduced need for repeat keratoplasty probably outweighs the probable reduced visual acuity in dark cases. So when you want to start manual dark procedures, there is the drawback of a relatively flat learning curve, a long learning curve, which has the risk of unintentional penetration during manual side cut, the risk of unintentional penetration during the big bubble maneuver with a sharp needle or a cannula, and if you cannot achieve this big bubble, there is an unknown residual stroma bed thickness when you perform manual dark procedures. So the femtosecond laser might be a tool that really helps in these cases. We know that femtosecond laser can help you to get better side cut geometry. It can help you to get better centration of the trephination. It will lead to less damage of endothelial cells in the donor, and you have a very high accuracy concerning the depth of the cut. Additionally, the Ziemer platform also provides an intraoperative OCT scan, and this helps to precisely measure the patient tissue or the donor tissue during the trephination, and it enables to adjust the planned incision intraoperatively. The group of Seiler and Jodmeta recently published the high precision of the OCT-guided incisions, and this helps to enable the device to cut very closely to the Descemet's membrane, which the company used to introduce the dark tunnel, which is a platform to insert your dark cannula very closely to the Descemet's membrane. So when we use this device, we can adjust the lamellar cut, the side cut, and we can use this device to adjust, to keep the safety distances to the endothelium. And further, we also can adjust the dark tunnel very closely to the endothelial cells, to the Descemet's membrane. And the company will in the future provide a new software update, which should come in the next months, which will provide a color-coded and simplified projection, and also the possibility to perform mushroom dark procedures, which will have additionally benefits for the outcome of dark procedures. To evaluate these developments, we designed a multi-center trial where we retrospectively evaluated prospectively collected data of 2 surgical centers with manual dark and femtosecond laser dark cases between 2011 and 2017. Those centers were the Department of Ophthalmology in Vienna and the IROC Institute in Zurich. Patients were divided in two groups. In the manual dark groups, we included 51 eyes, and in the FEMTO dark groups, 73 eyes. The study design included patients with an average age of about 40 years in the manual and in the FEMTO group. Male patients were more than female patients, and most of the patients, about 75%, had keratoconus, and the residual parts were mainly stromal scars or disc corner dystrophies. We investigated the rate of successful big bubble achievement, the rate of micro or perforation of Descemet's membrane, rate of conversion to penetrating keratoplasty, rebubbling rates, and surgical time. Clinical parameters were evaluated as visual acuity 3 months of the suture removal and mean keratometry in the two groups. When we look at the successful type 1 bubble achievement, we had an increase in type 1 bubbles from 71% to 82% when using the femtosecond laser. This difference was not statistically significant. However, the rate of microperforations or perforations dropped significantly from 42% to 19%. Also, the rate of conversion to penetrating keratoplasty dropped from 33% to 12%, which was also statistically significant. The rate of rebubbling dropped from 15% to 5%, although this difference was not significant. And in our center in Vienna, we also evaluated surgical time because the introduction of a femtosecond laser might increase the burden in the surgery room, but that was not the case. Surgical time was comparable between manual dark and femto dark. Further, there were some differences between the two centers. Both had an increase in successful type 1 big bubble achievement and a drop in conversion rates. However, there have been differences in the rates in the two groups. We see that the conversion rate was higher in the manual dark group in the center 1, as well as in the femto dark group in the center 1, compared to 0% in center 2. We had 18% of conversions in center 1. On the other hand, we see that the rebubbling rate was inversely correlated to the conversion rate, means that the conversion rates and rebubbling rates are in some cases surgeon dependent, but in both cases we found an increase in successful dark procedures when using the femto laser. Further, in the Vienna group, we found that in the manual dark group, we had 4 cases of unintentional perforations during the manual trephination or needle insertion. And this was never observed in the femto dark group in the Vienna study site. So no case of cut-related complications were observed in the femto dark group. Visual acuity after suture removal, as well as mean keratometry, was not statistically significant between the two groups in any of the centers. So in conclusion, we found a significant lower rate of perforation or conversion to penetrating keratoplasty in the femto dark group. We had no case of unintentional perforation during trephination or cannula insertion in the femto dark group, and we had a high big bubble success rate in the femto dark group. So the femtosecond laser increased the reproducibility of dark surgery and likely helps to make dark surgery more accessible to unexperienced surgeons. And as an outlook, the new mushroom dark software might further increase the success rate due to the smaller internal transplant diameter, which would help since dual layer anatomically is limited to the central 7.5 to 8 millimeters. Thank you very much.
Thank you, Joe. That was very interesting. So just a quick question I was going to ask, what's the, you showed there seemed to be a shorter learning curve with this procedure, and the most of the cases you've shown have been keratoconus. Do you think, what is your ideal case that, say, somebody is going to start off with? Would you ask them to start with a cone? Would you ask them to start with a post-infectious scar? Or would you ask them to start with a corneal dystrophy case? What will be the first case you'd ask a novice surgeon to start with?
I think that keratoconus might be a good case to start off. Corneal dystrophies might be difficult, especially some type of dystrophies are difficult to perform a dark surgery. Stromal scarring, if they're superficially, it should be okay. but I would try not to do dark surgery as first cases with deep scarring or in cases with keratoconus with deep scarring, because they have higher risk of unintentional perforation.
Okay, great. Okay, thank you, Joe. Thank you. So the next speaker is myself. So I'm going to be talking about, keeping on the same theme with corneal transplantation, about liquid keratoplasty. So these are my financial disclosures. So it's been over 115 years since the first corneal transplantation was performed in Europe by Edward Ziemer. And mainly the procedure hasn't really changed a lot over really that time period. And despite the fact there's been improvements in surgical technique, the full thickness transplantation of the cornea became the hallmark for the way corneal transplantation was performed. If you look at data from the Eye Bank Association of America, you'll still see, regardless of the fact that we're doing a lot more endothelial keratoplasty surgery and it's becoming the most dominant procedure, there is still a significant amount of full thickness penetrating keratoplasty performed not only in the US, but basically also around the world. And the key fundamental part of the keratoplasty procedure is actually the vertical trephination. Over the decades, we've seen an evolution in trephination from no suction trephines like the Solan you can see on the left-hand side over here, that are good to use in cases of perforations or dysmetaseals. Also cases in which there may be no undercutting of the edge of the tissue itself. But there can be problems with centrations and often getting issues with getting around trephination with these kind of trephines. Suction trephines became more popular. They were fast to basically cut, but they can cause raised intraocular pressure inside the eye and undercutting the edge of the tissue while they're doing the trephination. Centration can be a problem, and often you get a donor-recipient mismatch with both these trephinations. And this is what I mean by the mismatch that you will get, since the donor is cut from the endothelial surface and the recipient is cut from the epithelial surface. So often you'll get a matching on the anterior surface, but you will get a gap over here on the posterior surface when you're basically doing your suturing. So the thought has always been that if we could induce the femtosecond laser into this technology, we may be able to improve on some of these things by removing or reducing the amount of undercutting of the edge. Can we keep the IOP a bit more stable inside the eye? The femtosecond laser should allow us to do different shapes. And of course, we can cut the donor and the recipient both basically from the same side. So we can cut it from the endothelial side up towards the epithelium. So we should be able to get a much better matching of our transplantation procedure. So a few years back, we published this paper in IOVS back in 2012, where we actually looked at the effect of the intraocular pressure in a rabbit eye, and we used this rabbit manometer in the anterior chamber to check the intraocular pressure. And we compared a femtosecond laser to that basically measurement using a manual trephination. And what you can see is if you look at the red line over here in the manual, you see during the manual cutting, the IOP can actually rise quite sharply, and it can be all over the place compared to basically when the suction is on. And this is because you're getting a prolapse of tissue as you're basically doing the cutting into the obturator. But with the femtosecond laser, this is actually much, much more stable. If you look at the endothelial cell damage around the margin of where you cut, so this would be example cutting basically the donor tissue, you can see with the femtosecond laser, you get very little damage to the endothelium and a much cleaner cut. While with the manual trephination, you get a much more significant damage around the endothelium itself. And if you look at this in a real quantity terms of number of cells, you get about loss of 4,000 cells with the femtosecond laser, but almost between 13,000 to 18,000 cells with the manual trephination margin. When you look at the undercut, the way you basically measure this is by looking at the distance between the anterior epithelium to the endothelium down in basically a straight line. And this area over here, you can see in the manual trephination, is what we basically call the undercut edge. And you can measure this angle. And what you can see is that you have a much reduction in the undercutting edge with the femtosecond laser, only 16.7 degrees, versus a typical manual trephination, which is almost 46.8 degrees of undercutting. And that's because you've got this prolapse of tissue into the obturator during the cutting as well. When we looked at inflammation, when you're comparing the femtosecond laser to trephination, you will see that you do get more inflammation around the wound healing edge of the grass-host junction. So you do get more early wound healing with the femtosecond laser compared to manual, and this will normally settle down after a few days of basically using steroids. So subsequently after this, we started a clinical study where we were using basically the laser. This was published in 2008. And subsequently after that, there have been a whole lot of papers published in the literature that have shown the safety and efficacy of basically doing FEMTO PK studies. Now, if you look at the studies, you'll see that it's been color-coded here in blue and also in orange. The blue studies are studies that have been done using a laser that uses a flat applanator, and the ones in orange have been done basically with ones that have been using a curved applanator. The thinking has always been is that if you use a curved laminator, you get less compression on the cornea when you're actually doing the cutting. But in fact, this is not actually true, because you can see from this diagram over here, when you're using a flat applanator versus a curved applanator, because it's a fixed curvature of the applanating surface, when you compress the cornea, you're going to get compression on the surface. And in fact, if you do OCT in human eyes, you will see these little folds if you're using a curved applanator, because of course the K reading is already fixed, and we all know that the K readings will vary in basically patients, and you will get these little folds on the posterior edge of the cornea following your curved interface. And of course, these will be more prominent basically if you have a flap interface. So if you want to avoid these folds to get a nicer, smoother cut on Descemet's membrane, there's only basically one way to do this, and this is basically using a liquid applanation. Now, using a liquid applanation system, there's a video showing over here of this happening in a pig's eye. You will see that, of course, the laser cutting is basically, there's a gap here and there's liquid on the curvature of the cornea. So basically, it takes the issue of the curvature of the cornea out of play. And if you do an OCT, you'll get a much smoother surface, like you can see in this diagram over here. As Gerald basically mentioned, the OCT software, the intraoperative OCT software, allows you to take 8 sections around the cornea to allow you to look at all the angles of the cornea before cutting your vertical rim cut. So you know exactly where you're basically placing on the surface, and you don't get these folds on the cornea like I showed you on the previous videos. So we wanted to study this, comparing it to the flat applanator with respect to different energy settings, with respect to intraocular pressure. And what you can see is, in this study, is that you can see there's less intraocular pressure variation with a liquid applanator compared to the flat applanator. And this is regardless of the energy we use, 150 all the way down to basically 30. The second point is that the liquid applanator actually showed very similar readings to intraocular pressure to what we've previously published using a curved applanating system. But of course, the big advantage of this is that there's no folds on the cornea. If you look at the endothelial cell loss, interestingly, if you look at 90% energy, the amount of damage to the endothelium around the edge of the cut is very similar between the liquid and the flat applanator. But when you increase the energy to 150%, which you may want to do in quite edematous corneas that are quite swollen, you can see there's significantly less endothelial cell damage in the liquid applanator compared to the 150. And in fact, there's no significant difference in the amount of endothelial damage whether you use 90 or basically 150 energy in the liquid applanation compared to basically the flat applanation. So how can we apply this to basically clinical practice? So there's a patient of mine. She's a 71-year-old lady. She has a whole herpes scar over here. She's been inactive for quite some time. Her visual acuity is basically 6/190. So you can see quite dense scar over here. On the OCT, you can see the actual scarring is actually quite deep. Now, people may basically opt to do a penetrating keratoplasty, but you can see some vessels over here. So you know it'll be quite a high-risk procedure. So in these cases, I still would elect to basically do a DOG procedure. So I did a manual DOG for her, which is a layer-on-layer dissection. But sometimes what happens in these old herpes scars, the deeper you go down, you often get to an area where they actually get fixed folds. And you can see these folds over here only became apparent when I was doing the surgery, because you can't see them preoperatively. So I dissected down to 50 microns to basically leave these folds here. Otherwise, you definitely basically rupture Descemet's membrane. Now, visual acuity improved to 624. She was reasonably happy, but I thought, you know, we could probably do something better with this to try to get rid of these folds for her. And this is basically what we did. So what we did is that we removed the bit of the DOG using the femtosecond laser liquid keratoplasty module inside the eye, and using the real-time intraoperative OCT to judge our depth of about 75 to 80 microns. So we can cut the lamellar tissue from basically the inside. So the advantage of the scan is you can actually do this real time, so you know exactly the thickness of the stroma. Once you've done this basically on the patient using the liquid interface, the scan will go all the way around, and it will fire upwards, basically cutting within to the DOG up to about 80 basically microns of tissue. Once it's cut, you can simply go around with a simply Sinski hook. So you can see there's a little bit of adhesion there where the previous sutures are, and you can remove the tissue. And once you basically remove the tissue, you can see the scar on the stromal tissue, and then I did a DMEC in the gap of where I'd moved basically the stromal tissue itself. So I replaced the endothelium in the central area. And the tricky thing about the DMEC, of course, you have to get it in that space that you've just created with the femtosecond laser, basically for your vertical cut. So once the DMEC is in place, which you can hold, you can basically seal it in place with an air bubble. So this is what she basically looked like. So this was basically 690 pre-op. This is 624 after her basically post-operative time period, after her DOG. This is basically 1 day after her DMEC. You can still see the gas inside the eye. And this is basically what she's like now, 6 months post-op. gets pretty good visual acuity, and you can see nicely on the OCT where we remove all the scarring, and she's got a new endothelium now, precisely from her DMEC. So in summary, femtosecond PK has several advantages over conventional penetrating keratoplasty surgery. You do get earlier wound healing because you get improvement in the wound healing response around the edge of the graft-host junction. You can remove your sutures earlier. There are various graft edge profiles you can use instead of just using perpendicular ones. You can basically use mushroom ones, and you can get a better alignment of not only the anterior surface, but as well as the posterior surface as well. The Z8 liquid keratoplasty module, I think, allows real-time intraoperative adjustment of that rim cut that you can cut. The 8 scans will improve your precision, as I showed you in our clinical example around the whole cornea. You get less damage to the donor rim, and also, of course, the recipient tissue, especially at high energy, which you need to do, especially if you're cutting through edematous, basically corneal tissue. And with the liquid interface, you get no folds from compression, as you get basically with curved and basically flat applanating surface as well. The lower IOP can be important because sometimes these patients, especially if they're more complicated, may have glaucoma, and it's certainly a lot lower than using a flat applanator. And you can use the system for simple penetrating keratoplasty cases, but also more complicated cases like I showed you in the example. Thank you for your attention. Now we're going to switch gears from cornea now, and we're going to basically move to cataract. So the next speaker is going to be Professor Chi, and she's going to be talking about his experience using the Z8 femtosecond laser in complex cataracts. Thank you, Patrick.
Good afternoon, everyone. So today I'll be talking about handling complex cataract cases with the ZA, my financial disclosures. So let's start out with a simple case. This is a soft posterior polar cataract, and you can see we've already done 8 segments and a capsulotomy of 5 mm. And we're just putting dispersive viscoelastic under the capsule in the subincisional areas and cracking along the crevices without any sculpting, and then joining all these cracks with sweeping movements at the equatorial region. And this loosens up the entire segment, and we can just aspirate this up with the femtosecond with the phaco machine, because this is really quite a soft cataract. This subincisional area is a little more difficult. That's why we've got viscoelastic under there to loosen up the nuclear fragment. And just picking off the fragments, they come easily towards the center. So we have removed the nucleus without any effort at all. And you can see there's been no rotation. So the posterior plate is still intact. There's been a cushion that protects the posterior capsule in case this thin posterior capsule gives way. And you can see this is just a 500 micron thick cortex that's been created by the femtosecond laser cut. And we're just aspirating this off from the periphery towards the center slowly in case the posterior capsule gives way. And you can see there's a little bit of a plug there, but that's what the patient started off with. So I'm going to remove this. I've just punctured the posterior capsule with a 27 gauge needle and performing a posterior capsulorhexis to clear this plug off the visual axis. And after this, we can still implant the lens inside the capsular bag, and the patient will have good vision the very, very next day and does not have to wait for a yet capsulotomy. Because the anterior vitreous space is intact, it's not a problem going under the intraocular lens to clear all the viscoelastic. We won't engage any vitreous, and then we tap the lens into position, and we can get a very good outcome with this. Now let's have a look at the next case. It's a little more challenging. This is a white on brown cataract, and you can see the fibrosis under the capsule. This is tough, right? And it's not something that you can easily tear or do a manual capsulorhexis. So we've got the femtosecond laser set to 150% of energy, and that's to treat this capsule with the fibrosis. Sometimes there's strands that are really tenacious, and you might just have to cut across this fibrosis, but you will notice that the capsulotomy was completely cut and free. So also with a very dense nucleus, we want about 150% of energy so that we can segment this, and this has been segmented again into 8 pieces. You can do 16 pieces with the Z8, which will make a denser cataract even easier to remove. And because these lines that you see here are really clean, you know this has been cleaved by the laser. So we just apply standard settings for this kind of a cataract that's not super dense, and we'll be able to remove this very quickly and very safely. And we have a nice, well-centered capsulotomy to implant our lens through. So you can see now the lens in place and the viscoelastic's been removed, and we have a good outcome for this patient with a very advanced cataract. Now, this is a patient with a rather tight pupil aperture, which is not uncommon amongst Asians, Orientals especially. Pupil is also small, so we've inserted a Malugian ring, and this has been done under dispersive, cohesive viscoelastic and has been removed. And because the palpable aperture is so tight, sometimes we cannot center this nicely. And so having the suture there actually helps us to position our eye right in the center of the patient interface so that we can perform the perfect capsulotomy and docking. So this is another complicated case. As you can see, we had to expand the pupil. We put in vision blue so that we can ensure that the capsulotomy has been completely cut in a white on brown cataract again. And I thought, well, this is not too bad. It's a bit denser than the previous case we're doing, but it's been cut well right to the posterior capsule. But as I was doing it, I noticed that the ring, Malugian ring, kept moving to one side. And then I realized that the bag was actually rather loose. And so I'm going to put in capsule bag hooks to support the capsular bag. And I'm going to recenter this ring so that I can proceed with my surgery. And you see here, actually, what had happened was one of the scrolls had caught onto this ring, and I was actually pushing it many times to try to center it without knowing what had happened. And yet, the femtorexis actually stood up to all this manual manhandling by the scroll. Okay, so it's a strong capsulotomy. And you can see now that we can proceed with this Malugian ring centered on the capsulotomy, and with the hooks actually supporting the equator, everything seems to be going on very nicely. And I'm progressively removing the nuclear fragments one piece by one piece, and slowly it's coming, and then something happens. Okay, you will see that this ring again is moving to one side. And I'm not comfortable because I think something has happened now. And indeed, actually, there's some fluid gone from the anterior chamber to the retrolateral space and is pushing my capsule forward. So I put in an RL as a scaffold so I can safely complete my surgery. I take out the hooks and I thought I'm done. But as I pull out the Malugian ring, as it folds, there's some vitreous that's just coming here. And so I know, because of the zonulisis, I have to clear this vitreous completely so that the patient will have no retinal issues. And I'm going for the pars plana approach to clear this vitreous after staining it with triamcinolone acetonide and clearing whatever strands I had seen here. And I'm going to fixate this capsular bag using a capsular tension segment with a Proline 6O suture, which has been something that Canabrava has described in the recent years. I just pull this out through the main incision. So I'm using 6O Proline. I load on the capsular tension segment and insert this into the capsular bag with the help of micrograspers into this location where the vitreous was seen popping forwards. And once I've removed all this viscoelastic, I then adjust tension of the suture, which I then create a flange, and this is the case that's now stable and the lens is well centered. So in conclusion, the Z8 femtosecond laser is a low energy enabling technology where complex cataract cases are made safer and also appearing far less difficult to the surgeon than what I had to face years ago. The Z8 has recently obtained CE mark for treating pediatric cataracts. And coming up soon also, the company has for us a new, smaller patient interface, especially for Asian eyes. And also, the best news is the new software that will halve the current nucleotomy times. So please visit the Ziemer virtual booth today for more information. Thank you very much for your attention.
Thank you, Prof. Chi. So the next speaker, I'd like to invite Professor Menapachi, also from Vienna. So we're switching from Europe to Asia and back to Europe again now. and he's going to be talking about low energy femtosecond laser for pre-treatment of macular thickness and effects on micromorphology. Thank you.
Good afternoon. I will be talking about the impact of low energy femto laser pre-treatment on macular thickness and micromorphology. We know that pretreatment with conventional high-energy femtosecond lasers has shown to provoke inflammatory reaction. This is due to prostaglandin, inflammatory cytokine, and the depletion of other factors. There is a paper out reporting on a significantly higher level of prostaglandins in aqueous immediately after high-energy femtosecond laser treatment, increasing the normal levels to a factor of 10 to 20. There are more side effects of high-energy femtosecond laser application, acidic shift, and temperature rise in the anterior chamber. Consequences of clinical side effects are intraoperative miosis, ocular hypertension, cystoid macular edema, and endothelial cell trauma. The new concept of Ziemer is low energy femtosecond laser technology. And the essence is that instead of using high energy pulses with low frequency, low energy pulses are used with high frequency. So the pulse energy is reduced to about 1/10, while the pulse frequency is increased by a factor of 10. This results in reduced spot size and energy. How is this attained? This is attained by reducing the angle of aperture or the focus lens by relocating the laser optics into the handheld applicator in close vicinity above the eye to be treated. So we investigated the impact of such a low energy laser on intraocular tissue trauma. We need sensors to describe or measure this trauma. There are two sensors. One is the level of inflammatory mediators in the aqueous, and we use prostaglandins and the interleukins as markers. And a second sensor is the macular thickness and the macular micromorphology. We know that if you induce intraocular tissue trauma, you get a rise of prostaglandins and interleukins, and you get central retinal thickness increase, irregularities of intraretinal structures, maybe subretinal fluid accumulation, intraretinal cyst formation, and finally, it might end up in cystoid macular edema formation. So we did a number of studies to answer the following questions. One is, does femtosecond laser pretreatment reduce ultrasound consumption? And second, how does femtosecond laser pretreatment impact intraoperative tissue trauma? By investigating aqueous inflammatory media levels and changes in the macular thickness and micromorphology. So there are two PGE studies performed investigating or comparing the post-operative prostaglandin levels after low energy femtosecond laser pretreatment, cataract surgery versus pure manual surgery, and one investigating pre-fragmentation first versus capsulotomy first. We published the results of PGE study number 1 recently and compared that to the literature reports on high energy femtosecond lasers. And you can see here that the prostaglandin overall prostaglandin levels after pre-treatment with a high energy level was significantly increased as reported before, while when using the low femtosecond laser, there was no increase in aqueous PGE levels. This is also also shown in a second study with high energy femtosecond lasers, that increase of PGE levels compared to no increase with our study. We also investigated the increase of cytokine release and compared that with a report from China. And again, while high energy lasers significantly increased the level of cytokines of interleukin 6 and 1 beta, the use of the low energy laser did not show any such increase. The second or third study we did was the FLAME study, and this was meant to answer the question whether the pretreatment reduces the ultrasound consumption and what are the changes in macular thickness and micromorphology. We had a similar study design years ago when we compared posterior optic buttonholing to standard capsular bag fixation of intraocular lenses. And this showed, you can see at that time, the high resolution OCT imaging showed there was no difference between the two eyes. And you can also see that the increase in retinal thickness was not statistically significantly different in both groups. Even more, the numbers were almost the same in both groups. So we applied the same study design to the study comparing the impact of low energy flax versus manual cataract surgery on the macula. We both surgical techniques were exactly the same, with the only difference that manual capsulorhexis was used in the one group versus femtosecond laser capsulotomy in the other, and that manual 4-sector nucleus division was used in the one group, while a 6-sector femtosecond laser nucleus division was used in the other. You can see here the two videos in both groups that compare the techniques. The patients and methods, it was designed as a prospective randomized intra-individual comparison that was statistically powered, 50 patients. Comparable mean nucleus hardnesses were selected, log3 grade 3, and only one experienced surgeon using the same standardized surgical technique did all the surgeries. FEMTO group, Ziemer Z8 LDV, low energy, femtosecond laser, pretreatment, and phaco in both groups, ultrasound-assisted forced fluidic phacoaspiration. The outcome measures were intraoperative effective phaco time as a measure of ultrasound consumption, and central macular thickness and micromorphology pre and 1, 3, and 6 week post-surgery, as assessed by high-resolution OCT imaging. Concerning the results, effective phaco time in both groups, not different. Generally, the EPT was very low. You can see it was in the manual group 1.9 seconds and in the laser assisted group 1.8 seconds with no statistical difference. Regarding macular thickness, means and SDs, you see here that both groups were essentially the same. There was no statistical difference. You can see here the thickness was 275 microns in the means pre-op and 1 week post-op, and 280 at 3 weeks and at 6 weeks. This is shown as box plots and as histograms, and shows that both groups were have the same thicknesses of macula in these timeframes. Also, differences between groups were not statistically significant different. So the conclusions are: FLAME is the first study that intra-individually compares work of nuclei of comparable hardness with and without femtosecond laser pretreatment. With the specific ultrasound-assisted forced fluidic phacoaspiration technique and instrumentation used, no difference in effective phaco time as a measure of ultrasound consumption was found. Workup of the pre-sectioned nucleus, though, was experienced optimally controlled, easy, and safe. As previously shown for aqueous PGE and interleukin 6 levels, no difference in post-operative macular thickness was found with the additional use of a low-energy laser. So Z8 low-energy femtosecond laser pretreatment does not induce intraocular tissue stress. And second, though not found in the present study, femtosecond laser pre-sectioning of the nucleus may help save US energy and make nucleus workup easier and safer when less efficient techniques and instruments are used. Thank you very much for your attention.
Thank you, Rupert, for that interesting talk. Can I ask just one question? So one was pertaining to the study. Did the patients use the any non-steroidal inflammatory drug after the operation, or was it only as a pre-treatment in the femtosecond laser group? And the second thing is that whether you could just make a comment about energy settings as well that you will use for the femtosecond laser with respect to the density of the cataract, so the fragmentation and the capsulotomy energy.
Yeah, the capsulotomy energy was set at 90%, and the for nucleus 3 grades was set at 120%. And in PGE study 1, we only used 1 drop of NSAID preoperatively half an hour before surgery. And in the second group, comparing capsulotomy first versus fragmentation first, we did not use any NSAID pretreatment at all.
Great, thank you very much. So now we move to the last bit of the program, and we're going to shift gears a little bit and be talking about refractive surgery, because you're all thinking we've left out all the people from South America. So this is the moment now we move to South America as well. And what we're going to be talking about is an exciting new feature of the Z8 femtosecond laser, which has the acronym CLEAR. Now, CLEAR stands for corneal lenticle extraction for advanced refractive correction. And effectively, it's a lenticle extraction procedure that has recently gained CE mark in Europe in April this year. So despite the whole COVID pandemic, some people were still working to be able to get this through the European system. Now we have some speakers from South America. We have Luis and Arturo as well, who both have a lot of experience, initially with the CLEAR software. But to start this section, I'm going to invite Professor Theo Seiler, who's going to be giving a little bit of introduction to CLEAR and explain about how the procedure works and how it works with the Z8 system. Thank you, Professor Seiler.
Friends and colleagues, if you move through the booth in Amsterdam, either virtually or in person, you may see a whole stable of racing horses called femtosecond lasers. And some of them, like those 3 in the upper part of the thing, are just used for special purposes. So the femtosecond laser here is for cataract. That one is a femtosecond laser used only for flap making and keratoplasty, and that one is again for cataract only. And then we have 3 remaining systems: the C8 from Ziemer, the VisuMax from Zeiss, and the ARTUS from Schwind, that can make lenticle creation, intrasomal lenticle formation that can be used for refractive purposes if they are extracted. Now, if you compare them at the first glance, you see the C8 has the lowest energy per pulse, less than 0.1 micron, and the VisuMax from Zeiss has the highest. Also, the repetition rate of the C8 is much, much higher compared to that of the VisuMax, and substantially higher than of the ARTUS. And now the question is, does that make a difference? Yes, it does. We know from the old days, femtosecond LASIK times, that there was the so-called light sensitivity syndrome that was induced by the roughness of the cuts of the femtosecond laser, flap cuts. Now, if you look now look into detail of a SMILE situation in the interface, you may see a lot with confocal microscopy. You see a lot of roughness compared to the LASIK flap formation done with a femtosecond laser from Ziemer. You see also there's a lot of backscattering shown in the lower part of the presentation. And that backscattering is a sign also for forward scattering. And that has been the explanation of the light sensitivity syndrome. So extrapolating from here, you can see that the smoother the surfaces that you create, the less light sensitivity you will see. And that's what people that have been treated with SMILE, they need up to 3 months to get rid of the glare and to build up full visual acuity. Next thing is the applanation of the surface, and Professor Mehta already made a point on that. We do have a planar applanation in the C8 and some curved in the VisuMax and the ARTOS, whereas where the VisuMax curvature radius is 22 millimeters and the curvature radius of the ARTOS is less than 20. Nevertheless, and does this make a difference? Yes. If you look at this cornea with a curvature radius of 8 millimeter and the curvature of the interface, you may recognize that there is extra tissue if they are applanated, which means if that from here to there, the touching points is wider than that one, we will have to live with the fact that the cornea has to be contracted or fixed, and this is as a response you get those undulations of the cornea because that line is bigger than that one. So in essence, those undulations can be calculated from the shortening of that scene between the touching points, and that's what we did. And you may have recognized, and this is a normal eye, the other one was a keratoconus eye, fixed at 9 millimeter by a suction ring, and then you create these undulations, and they are very much depending on the curvature of the interface. If it's plain, you get about 80 microns of undulation amplitude, and it comes down the more curved the interface is. Now, if you look at the VisuMax or the ARTOS, that is not much different from having no curvature at all. And a significant effect in getting a smoother surface inside the cornea will be achieved only at curvature radii of 10 millimeters and less. So in essence, if I'm comparing the three systems in the field, there's not much difference whether it's planar or it is slightly curved. Actually, that is just a little bit of a marketing instrument rather than a physiological benefit. Now let's go to the next case. This is a case after SMILE, has been treated here in Switzerland. And that's what we see all the time. It's a clearly descended ablation, or if you call it flattening zone. And the question is, couldn't we have centered that lenticular extraction more properly? And therefore, you need a kind of lateral movement of your femtosecond laser pattern, which is available in the C8. Yes, we do have an automatic centration. Once the eye is sucked on, that lenticle is automatically centered either on the pupil center or on the vertex. That is your decision, and you will have to program that. And it could be easily laterally adjusted if you don't like that centration. This is not possible with the VisuMax right now, and this is also possible with the ARTOS. We do have the cyclotorsion control implemented in the ARTOS. Nothing like that is in the VisuMax, and the C8 is still working on that, but it will be very soon be able also to do the cyclotorsion control based on the iris image. Now, the last thing I would like to add is something that I feel is very important. If you have your cornea and you create the lenticule, you would like to have two different approaches. And why is that? Remember, if you go in through one port, you always have the problem, am I on top of or am I below the lenticule? And for beginners, it's a really difficult decision. For people like Jod, who has done thousands of that, it's not a big deal. But for people who are starting with clear, they may benefit from these different ports, and you may see such a port that we did already 9 years ago. That is the anterior approach to the that ends up over the lenticule, and that approach that ends up below the lenticule. And with your spatula, you can very easily just separate the two planes or the levels, and you do not confuse it. Because if you don't, if you may not create a very nice dissection manually, some parts of the lenticle will stay in and creating irregular astigmatism. And I'm seeing at least 2 cases like that per year in my practice here in Zurich, with residual lenticular particles in the interface. So that kind of approach, the intelligent approach, makes our life easier and clear, most probably safer, and shortens the learning curve significantly. Now, in summary, you may see that the 3 machines in the field can do a lenticular extraction preparation with the femtosecond laser, but some of them can do it faster and less problematic with smoother surfaces. You can in those cases, you can also center your lenticule after you have sucked in the eye and you're not stuck with the suction process. And the cut patterns that is used is different in all 3 machines, but doesn't play a role. Thank you very much indeed for your attention.
Thank you, Professor Seiler, for that excellent talk, giving an overview of the CLEAR procedure. So I'd like to invite our colleagues from South America now. So we have Professor Esquerdo, who's probably the most experienced person at doing the CLEAR procedure, and Professor Chad, also who's done a lot of experience with the CLEAR procedure as well, to have some comments now for this discussion. So Louis, let's start with yourself. So what I want to ask is that you were quite new to lenticular extraction before you started the procedure. And I think that will be interesting for people to know, because there'll be a lot of novice surgeons listening to this webinar. And what the key features do you think that has the advantage of CLEAR over other lenticular extraction technologies?
Okay, I think the 3 most important things could be a low energy concept that can overlap the spots and give us more smooth surface. The second one, centration during an active vacuum, and the other one, the possibility to use 2 different ports, one for the anterior and the other one for posterior. I think that could be really important to identify the lenticular age, especially, for example, for low diopter correction, and also, especially like you say, for the learning curve, to avoid the most worst complication, that is lenticular rupture during the section.
Arturo, if you've been doing CLEAR as well. So what would be your advice or experience about with respect to centration? Because centration can be difficult with other lenticular experiences because you're relying on the patient to basically fixate. I mean, do you use the internal fixation for the centration, or do you basically adjust it on the laser?
Yes, so what we do is we place 3 marks, 2 marks horizontally at the 0 and 180 degree, and then we place a mark inferiorly at 90 degrees. And what we try to do is to match the 3 marks with the Myers that we see at the laser, and that has been extremely easy and accurate to do. So that's how we center, and we love the fact that we can move the centration, and that gives us a lot of peace of mind, and it's been very reliable.
Professor Seiler, just following on your talk, I mean, it was interesting to see the differences between flat and curved applanation. I mean, a lot of people ask about that, about would that affect lenticule? Do you think it would affect the amount of treatment you can do if you're using a flat applanator or a curved applanator with respect to the higher dioptric powers?
I'm absolutely sure that this does not make, in the current version, it doesn't make a difference at all. Whether it's plain or it's slightly curved doesn't make a difference at all. It might be very different once we have curved interfaces with a curvature radius of 10 millimeters or less. Then there might be some adjustments, and I could imagine that we would create much, much better asphericities of the cornea using then lenticular extraction. Currently, it's a little bit more or less. Remember that some people have a cap thickness of 120 microns, others use 150 microns, and you get reasonable differences regarding the asphericity of the flattening zone.
Louis, so back to yourself again. So a lot of people say that one of the things they worry about, certainly when they're doing lenticle extraction, is it's certainly longer than making a LASIK flap, and suction loss can be a little bit of an issue. And you know, whenever we're doing lenticle extraction procedure, what is your experience with people who get suction loss? And if they get it, what do you do when they get suction loss?
Okay, you know, I started since from the beginning with Ziemer, and what I like most is especially the vacuum concept with them. I did many LASIK flap with the FEMTO, and really hard to have any problem for vacuum. And could be this really important also because, you know, the vacuum with the Ziemer platform is on the sclera, and also can help us to give us, you know, a larger diameters for the lenticulum that could be in the future really important for hyperopia correction. So I think it's really important, and I really don't have issues during the procedure with the vacuum system of the Ziemer platform.
Great. Okay. And the timing is about, I mean, approximately about 29 seconds. For the actual lenticle procedure itself with the Z8 for the clear extraction. So Arturo, I just want to ask you about another question that people often ask is about nomograms. What are you programming with the laser? We know that there are a lot of different nomograms that people use for lenticle extraction. So what are you actually doing with the program? Are you programming manifest refraction, or do you alter it like we do with our LASIK patients? What are you actually programming for your patients undergoing this procedure?
So far in the cases, we have a dial manifest refraction, and so far it's been very good, and results are being also very accurate. We need to do, obviously, much more cases to make sure that, you know, especially when combining with astigmatism, the nomograms will be very accurate, but so far it's been great just using manifest refraction.
I should mention that Ziemer is planning to do prospective studies in Europe with at least 100, most probably 300 study size. And as a part of these studies, or the important part, is to get nomograms that are reliable and that you can, that even the new guys can rely on.
So I'll just fill us off some regulatory information so it's everybody to know. So currently the laser is approved for use for for minus 0.5 diopter sphere up to basically minus 10, and also cylindrical correction from 0 to basically minus 5. But as Professor Seiler mentioned, obviously collecting data is going to be important to establish nomograms for basically everyone to use. If you'd like for more information about any of the talks that you've heard today, please go to the virtual Ziemer booth and contact your Ziemer for more details, especially if you want to hear about the keratoplasty module, the cataract module, or obviously the new exciting clear module for refractive surgery. So thank you all for attending. I wish you a successful meeting in Amsterdam, either in reality or virtually, and I hope that we will see each other again sometime soon, probably in the new year. Thank you very much.
Bye-bye, guys.